Hey guys, welcome to our last section on managing specific hemopoietic disorders. Let's go ahead and get started. When we think about these diseases, as we've talked about, these hemopoietic diseases throughout this lesson, we're going to go into more detail for some of the more common ones that you might encounter in the pre-hospital setting. It's important to remember that many hematologic problems occur in conjunction with other illnesses. For example, someone who has cancer or significant renal disease quite commonly will have coexisting anemia. In the following sections, we're going to examine diseases of the red blood cell, and these are the most common hemopoietic problem that we encounter. Second, we're going to look at white blood cell disease. These include things like leukemias, lymphomas, and other similar illnesses. Finally, we're going to present the disease of platelets and blood coagulation along with other hemopoietic disorders. When we think of diseases of the red blood cell disease results in too many red blood cells, too few red blood cells, or improperly functioning red blood cells. An excess of red blood cells is called polycythemia. Although it's uncommon, several conditions can cause polycythemia. An inadequate number of red blood cells or inadequate hemoglobin with red blood cells is referred to as anemia. Anemia is common, and several types are frequently encountered for us in the pre-hospital setting. Finally, red blood cells function can be impaired. Most commonly, this is due to problems with either the hemoglobin structure and function or the red blood cell's membrane. Problems with the red blood cell function include a number of different components, including things like sickle cell anemia. So when we think about anemias in general, one of the first things that we have to think about is that it's the most common disease, right? Truly, it's not necessarily a disease, but anemia is a sign of a separate disease process. In this case, hematocrit is less than 37% in women or less than 40% in men. We would consider them to be anemic. Most of the signs and symptoms that you're going to associate with have to do when the body's under some sort of stress. The body's response to a given stressful situation is not enough to keep them at their normal homeostasis level, right? So they're not going to get enough oxygen to the tissues because of the anemia. Now, this is different than chronic anemia, right, from an acute episode. You can become anemic acutely for issues that are associated with blood loss because of maybe a stomach ulcer. Or it can be more of a chronic problem because of an underlying disease, or maybe they've got problems producing red blood cells, and so that's going to be a more long-term effect behind that. Regardless, the symptoms and the treatment are going to be the same, right? Maximize your oxygenation, limit blood loss, establish IV access as indicated. That's going to be some of the more common things that you're going to take a look at. Now, there's a number of different anemias, types of anemias that are going on in your throughout your textbook here. So refer to table 9.2 with the types of anemia. We can see that the causes of inadequate production of red blood cells, that's a aplastic type of anemia, failure, again, just to produce those red blood cells. Iron deficiencies, sickle cells, another big one we think of, sickle cells, is a genetic alteration that causes the production of the hemoglobin that actually changes the physical shape of the red blood cell from being more of a circle or almost like a donut shape into more of a C shape, or what you refer to as like a sickle, especially in low oxygen states. Increase in red blood cells, that's a hemolytic, that's going to be where the body destroys red blood cells at a greater rate than production. That can lead to, again, problems with oxygenation. And then other chronic diseases. Hemorrhage leads to cell loss, whereas excessive fluids lead to a dilution of red blood cell concentration. Now, when we think of sickle cell disease, often termed sickle cell anemia, is the disorder of the red blood cell production. Normal hemoglobin is very flexible, and the red blood cell can pass easily through the tiny capillaries where it needs to. Sickle hemoglobin has an abnormal chemical sequence that gives red blood cells a C, or that sickle shape, when oxygen levels are low, right? So patients with sickle cell disease will have a chronic anemia that results from the destruction of abnormal red blood cells. That's, again, another example of a hemolytic anemia. The average lifespan of a sickle red blood cell is 10 to 20 days, compared to that to a normal red blood cell, which is about 120 days. In addition, the sickled red blood cell increases the blood's viscosity, right? So it leads to sludging and obstructions of the capillaries and small blood vessels. When we get these blockages of blood flow to various tissues and organs, It is common usually occurs following a period of stress, right? So we get this these blockages of these sickle cell red blood cells throughout these small capillaries and vessels, typically because of some type of stress. And we refer to that process is referred to as a vaso-occlusive crisis. It's characteristic of sickle cell anemia. Because vaso-occlusion crises occur, tissues and organs are eventually going to be damaged because of that. And adult sickle cell patients often have multiple organ problems, right? Not just one, but multiple organ problems, including cardiopulmonary disease, renal disease, and neurological disorders. Most of these situations that we're dealing with, we can actually affect, right? So, or probably cannot affect in the field, but we can recognize it. Sickle cell disease is inherent, right? So it gets passed from generation to generation. It primarily affects African Americans, although other ethnic groups can be affected. Really, we see it primarily in African Americans. These include things like Puerto Ricans and some people of Spanish or French, Italian, Greek, or even Turkish heritage. Both parents carry the gene for sickle cell anemia, and the chances are somewhere between 1 in 4 that the child will actually have a normal hemoglobin, so 25% chance. The chances are 2 in 4 that he will have both a normal hemoglobin and sickle hemoglobin, which is referred to as the sickle cell trait. The characteristics are 1 in 4 that he will have only sickle cell hemoglobin, no normal hemoglobin at all, and that is then referred to as sickle cell disease. Most of these patients with sickle cell disease, we're really going to be paying close attention to their vaso-occlusive crisis, right? Because they can cause things like musculoskeletal pain, abdominal pain, priapisms, pulmonary problems, renal crises, central nervous system issues like cerebral infarctions or even renal infarctions that can happen. And all of that can be part of the hemoglobin level and the problems that are associated with the shape of the red blood cell. Finally, sickle cell patients oftentimes will develop what's called an infectious crisis. An infectious crisis, they are functionally immunosuppressed. And because of that, they lose, because of the loss, of spleen function, it makes them particularly vulnerable to encapsulated bacteria. Infections from that point become common, and they're often cause death to the sickle cell anemia. Most of the care that you're going to provide for pre-hospital care for a patient with sickle cell anemia is supportive, again, like we talked about. We want to make sure we begin high concentrated oxygen if they're hypoxic to saturate the hemoglobin as much as we possibly can. We want to initiate IV therapy with a crystalloid isotonic solution. And these patients are often going to be dehydrated and fluid sometimes will help with the vaso-occlusive process. Venous access is sometimes difficult in older patients with sickle cell disease because of the large number of IV starts that they've had over their lifetime. Placing a central line on occasion may be necessary. Not something we're going to do, but we may have to have the hospital do. The vaso-occlusive crisis can be extremely painful. For that case, we want to start analgesic therapy in the field, and if possible, maintain their pain during transport. Oftentimes, these patients are going to require a large amount of narcotics for pain control. Always consult medical direction if there's a question regarding pain management, and then transport them. Obviously, that transport is going to be indicated in these cases. Now, polycythemia is an abnormally high hematocrit. This is due to excessive production of red blood cells, and with polycythemia, it's a relatively rare disorder and typically occurs in patients 50 years of age or older. The polycythemia is related, it can occur, secondary to dehydration, and then we also see the increase in red blood cell load increases the patient risk for some type of thrombus or clot. Most deaths occur because of a clot. Now, the signs and symptoms that polycythemia present with will vary. The principal finding is a hematocrit of 50% or greater. Typically, the patient usually will have an increase in number of white blood cells and platelets as well. Most patients with polycythemia may complain of things like a headache, dizziness, blurred vision, itching, gastrointestinal disease, and in severe cases can have congestive heart failure. The treatment for polycythemia in the pre-hospital care setting is going to be supportive. ensure that there's an airway and that the breathing is adequate, administer supplemental oxygen if they're hypoxic, initiate IV access, again with that crystalloid isotonic solution. And the principal treatment is going to be phlebotomy, which is going to be removing the excessive amounts of red blood cells. Now, when we think of diseases of the white blood cells are the body's principal defense system, right? The problems with white cells typically result that there's not enough of them. There's too few of them, right? We call that leukopenia. Too many white blood cells, that's leukocytosis. Or improper white blood cell function, right? So either too many, too little, or they don't work properly is really what we look at when it comes to diseases of the white blood cell. A reduction in the number of neutrophils is another component, right? Remember that neutrophils is the main blood component protecting against bacterial or fungal infection. So a reduction in these number of neutrophils, neutropenia, predisposes the patient to either a bacteria or a fungal infection. Now, if we look at leukopenia and neutropenia, the status of white blood cells is easily determined by obtaining a complete blood count. Now, we're not necessarily going to do that in the field, but if we were able to have that information as far as the transfer goes, we would know that a normal white blood cell count ranges from 5,000 to 9,000 per cubic millimeter of blood. We would see a decrease in this of white blood cells, which would indicate a problem with white blood cell production in the marrow or destruction of the white blood cells. So for some reason because of that. So because bacterial infections pose a major risk to humans, an absolute neutrophil count is a better indicator of the immune system status. As far as pre-hospital treatment goes for leukopenia or neutropenia, it's mostly, again, going to be supportive. Pay close attention to preventing infection and recognize that his immune system at this point in time is most likely already overstressed. With leukocytosis is an increase in number of circulating white blood cells. So now we're dealing with too many. This occurs when the body is exposed to an infectious agent or is particularly stressed. Following exposure, the immune system is stimulated and the marrow and spleen start releasing white blood cells to help the body fight whatever the infection might be. Typically, again, knowing what normal white blood cell count would be, we should see something between roughly 10,000 and 23,000 per cubic millimeter of blood, and that's going to be characteristics of a bacterial infection. The actual numbers is 10,800 to 23,000 would be an indication of some type of bacterial infection. Now, during these periods of stress, these immature neutrophils may be released into circulation, right? They're being released early because these cells are going to try to come in and to help in any way that they can. Now, they differ from mature neutrophils in that they have a segmented nucleus, and these cells are then referred to as bands or segs as part of that process. Now, an increase in the number of bands is indicative of a significant bacterial infection, right? Not only are we having more white blood cells, but we're having immature white blood cells released as well. Kind of lets us know the severity of the infection. Causes of leukocytosis include things like bacterial infection, rheumatoid arthritis, DKA, leukemia, pain, and then, believe it or not, even exercise. Viral infections tend to have little effect on the white blood cell count, right? And in some cases actually cause a decrease in the number of white blood cells being produced. A white blood cell count greater than 30,000 per cubic millimeter is called a leukemoid reaction. And in this case, a white blood cell counts that high, right, that are leading to 30,000 or higher, indicates a problem with excessive white blood cell production, not necessarily an infection. And any patient with significantly elevated white blood cell count should be evaluated for possible leukemia. And so we're trying to recognize, is it an infection? If it is, more likely to be bacterial or fungal. If it's above 30,000, it's more likely that it's going to end up being leukemia. So now let's take a look at leukemia. Leukemia are cancers of the hemopoietic cells. They're precursors of the white blood cells in the bone marrow, and they begin to replicate abnormally. The cells proliferate initially in the bone marrow, right? They're generated in the bone marrow initially and then spread to the peripheral blood. Leukemias affect approximately about 13 in 100,000 persons, and they're all classified in a multitude of different types. Most of the types that we typically deal with here, it's going to be impossible for us to determine in the field, but we can pay close attention to the specific types of signs and symptoms, right? So the signs and symptoms for leukemia vary. Most patients will have moderate to severe anemia as the cancerous cells produce, that begins to overwhelm the bone marrow. We also see an abnormal decrease in platelets, and this is common for the same reason. Many leukemia patients will present with bleeding, usually due to some type of underlying clotting disorder. With the initial presentation, leukemia patients will appear acutely ill. They may be febrile or even weak. Usually they're going to be feeling that way because of a secondary infection. That's how this normally comes to light. We may see various lymph nodes that are going to be enlarged, and patients are also going to have a history of weight loss and anorexia. In addition, the liver and spleen typically become enlarged, resulting in a sensation of abdominal fullness or abdominal pain. The sternum may also appear tender, secondary only to an increase in bone marrow activity, right? And then fatigue is a very common complaint. The big thing here is to recognize that mostly this is going to be brought on by a new onset of some type of secondary infection because their immune response is being blunted because of the leukemia itself. Lymphomas are cancers of the lymphatic system. Malignant lymphoma is typically classified as Hodgkin's lymphoma or non-Hodgkin's lymphoma. Typically, malignant lymphoma is classified by the cell type involved, which indicates the stem cell from which the cancer arises. In the United States, each year, fun fact, approximately 40,000 persons are diagnosed with non-Hodgkin's lymphoma, and only 7,500 are diagnosed with Hodgkin's lymphoma. The long-term survival rate is much better for Hodgkin's lymphoma, and in fact, many patients with Hodgkin's lymphoma who have been treated with radiation, chemotherapy, or a combination of thereof can actually be considered cured. The most common presenting signs of non-Hodgkin's lymphoma is painless swelling of the lymph nodes. The majority of patients with Hodgkin's lymphoma typically have no related symptoms. Patients with lymphoma may report things like fevers and night sweats, anorexia, weight loss, fatigue, even pertussis. Treating patients with lymphomas symptomatically is important, right? Place the patient in a position of comfort, administer supplemental oxygen if the patient requires it due to hypoxia, consider a fluid bolus if the patient is dehydrated, and if the patient is having pain secondary to the lymphoma, considers the administration of some form of analgesic. With lymphoma patients are definitely at an increased risk for developing infection. So make sure that you're employing proper isolation techniques, not necessarily for your benefit, but for theirs. Thrombocytosis and thrombocytopenia, these are going to really be dealing with diseases of platelets and clotting abnormalities, right? So there's a number of these that we will get into, but let's start off with thrombocytosis. Thrombocytosis is an increase in the number of platelets, usually due to an increased platelet production. It is also seen in polycythemia vera, in which the red blood cells and platelets are both increased. Thrombocytosis often complicates chronic other forms of leukemia. Thrombocytosis can be secondary to other disorders such as malignant diseases, hemolytic anemias, acute hemorrhage, and even autoinflammatory diseases. Most patients with thrombocytosis are asymptomatic, and the pre-hospital treatment is really just supportive. With thrombocytopenia, this is an abnormal decrease in the number of platelets. It's due to a decreased platelet production, either because of platelet production in the spleen, destruction of platelets, or any combination thereof. Many drugs can induce thrombocytopenia as well. There is what's called acute idiopathic thrombocytopenia purpura, or ITP. This results from the destruction of platelets by the immune system. It is most commonly seen in children following a viral infection. ITP is characterized by easy bruising, bleeding, and a falling platelet count. Chronic ITP usually occurs in adult women and is often associated with, again, underlying autoimmune diseases. Again, most care for this is really going to be focused around supportive care. Hemophilia now. Hemophilia is defined as a blood disorder in which one of the proteins necessary for clotting is missing or defective. A deficiency in factor VII is called hemophilia A. A deficiency in factor IX is known as hemophilia B, or Christmas's disease. And hemophilia A is the most common inherent disorder of homeostasis. The severity of the disease is directly related to the amount of circulating factor VII that's available. Patients who are classified as mild, moderate, or severe based on the amount of circulating factor VII that it's there. Hemophilia B is more rare, but it's also more severe than what you would see with hemophilia A. Now, when a person with hemophilia is injured, the bleeding will take longer to stop because the body cannot form a stable fibrin clot. Simple trauma such as nosebleeds or even a tooth extraction can lead to prolonged, occasionally life-threatening bleeding. An excessive trauma such as a pelvic fracture, blood loss can be overwhelming. A common problem with hemophilia is where we start to have bleeding into joint space. This can result from even the most minor trauma, and eventually, if repeating bleeding episodes occur, it can lead to permanent joint damage. Now, if we look at a person with hemophilia, we have to recognize that it is a sex-linked inherent bleeding disorder. And the gene with the defective information is carried on the X chromosome, and females, we know, have 2 X chromosomes, one from their mother and one from their father. And if one chromosome has the defective gene, then the other does not. The disease is not expressed. Females who have 1 X chromosome containing the defective gene are referred to as carriers, and males, however, have an X chromosome from their mother and a Y chromosome from their father. If the X chromosomes carry the defective gene, males will express this disease. Hemophilia A affects, in this case, right, that's what we're talking about, hemophilia A affects approximately 1 in 10,000 males. A female, on the other hand, can have inherent hemophilia only if she receives 2 X chromosomes that express the disease. That is, she must be the offspring of a carrier mother and a father with hemophilia. And so you can kind of get a look at what that would look like. If we look at, in this case, from a mother who is healthy and then who also has the gene carrier, most of the time hemophiliacs can be treated in the hospital with infusions of factor VII, right? And so in addition to factor VII, some hemophiliacs will require blood transfusions due to bleeding from some sort of trauma, or at least blood loss. Unfortunately, before blood and blood products were routinely tested, transfusion infected many hemophiliacs with HIV, Hep B or Hep C. Now, luckily, we have enough testing to make sure that does not actually happen. In the pre-hospital setting, the treatment-wise of the patient for hemophilia should still be comprehensive. The normal homeostatic mechanisms of vasoconstriction and platelet aggregation will still occur, but the platelet plug will not be stable due to the deficiencies of the factor VII. Now, you must also be attentive to prolonged bleeding or possible re-bleeds in your hemophiliac patient. The hemophiliac is at risk, obviously, of both, so our treatment needs to really focus around preserving and maintaining the bleeding control that we have in place. Administer supplemental oxygen if the patient is hypoxic, and initiate IV therapy with an isotonic crystalloid solution of normal saline. Be careful, though, to help prevent additional trauma, which can result in further hemorrhage. If the patient has sustained a joint injury, which results in hemoarthrosis, splitting the extremity will oftentimes be helpful, not only to help control the bleeding, but also to help control the pain. You may also have to occasionally go ahead and consider some type of analgesics as well. And again, we've talked about the primary management for our patients, supplemental oxygen, IV access, and then do whatever we can to prevent a new clot from busting. We talked about these again, the hemophilia A versus hemophilia B. Hemophilia A, we're talking that deficiency in factor VII versus a deficiency for hemophilia B and factor IX. Also, hemophilia B is referred to as Christmas disease. Now, if we look at von Willebrand's disease, typically we're going to see this again with factor VII actually consists of several different components. So one of those components that we deal with is the von Willebrand factor. This component, factor VII, is going to be what's deficient. Other diseases that we look into encounter in the pre-hospital setting include a number of them. One of the more common one is disseminated intravascular coagulation, or DIC. In this disorder, coagulation is caused by a systemic activation of the clotting cascade, the coagulation cascade. This is, in essence, we're getting a combination of a lot of different things that are going on. In DIC, circulating thrombin and fibrogen form clots through the circulation. This can be widespread. Mostly you're going to see this result from sepsis, hypotension, obstetrics complications, another of severe tissue or brain injury, cancers, or any other major hemolytic reactions. We also know that system activation of the clotting cascade, a lot of big words in this presentation, can have a lot of issues as well. And we really talked about primarily those. Definitive treatment really includes the administration of fresh frozen plasma and platelets. Obviously, it's something that we want to try to get them so they can get at the hospital. Multiple myeloma, this is cancer disorders of the plasma cells. These plasma cells are typically B cells responsible for producing immunoglobulins, or the antibodies that we have. This disease is rarely found in persons under the age of 40, and approximately about 14,000 new cases are diagnosed each year. Usually, multiple myeloma begins with a change in a plasma cell at the bone marrow level. Now, these cancerous plasma cells crowd our healthy cells and lead to a reduction in regular blood cell production. And so the patient becomes anemic and prone to infection. First sign that you're going to see with a patient with melanoma often is pain in the back or in the ribs. Those are going to be some of the biggest things that you're going to see that are going to occur. And this is the disease marrow is weakened, and weakened the bones, and the pathological features, those occurring with minimal or no trauma, the patient may occur, right? So fracturing of bones or issues with renal function all can play a role into that. Treatment of multiple myeloma includes chemotherapy, radiation, bone marrow transplants. Pre-hospital care is supportive. Establish an IV of crystalloid isotonic solution. Consider a fluid bolus if there's symptoms of dehydration. And remember, with multiple melanoma, it can be very painful. And so because of this, of the proliferation of the plasma cells and destruction of the bone marrow, you may want to consider analgesics for pain if it is severe. It is not uncommon for EMS to be summoned following some type of pathological fracture in the patient with melanoma. And again, these are very painful, and you should really consider analgesia if it's indicated.